Hello all. Today in this session we'll be discussing about adrenergic drugs and anti-adrenergic drugs. Myself, Dr. Sudhir PRUDHVI. So before going to start adrenergic and anti-adrenergic drugs, I would like to give a small introduction about nervous system. So nervous system is divided into central nervous system and peripheral nervous system. That peripheral nervous system itself again it is divided into somatic nervous system and autonomic nervous system. Central nervous system includes brain and spinal cord. Peripheral nervous system, it includes I told somatic and autonomic nervous system. Here our main concern is about autonomic nervous system. Autonomic nervous system itself, it is again divided into three categories: parasympathetic nervous system, sympathetic nervous system, and enteric nervous system. This enteric nervous system is present in GIT. So our main concern today is sympathetic nervous system. So I would like to say the other names of two nervous systems, parasympathetic and sympathetic. Parasympathetic nervous system is also known as craniosacral outflow, and sympathetic nervous system is also known as thoracolumbar outflow. Here we will see the brief thing about synthesis of this neurotransmitter epinephrine. So here in our adrenergic nervous system, the main neurotransmitter is norepinephrine and epinephrine. So here we will see the synthesis of those norepinephrine and epinephrine. So it starts with phenylalanine. Phenylalanine, it is converted to tyrosine, L-tyrosine, with the help of phenylalanine hydroxylase. That L-tyrosine is converted to L-dopa with the help of tyrosine hydroxylase, and later this L-dopa is converted to dopamine with the help of L-dopa decarboxylase. That formed dopamine is converted to norepinephrine with the help of dopamine beta hydroxylase. That formed norepinephrine, it is converted to epinephrine with N-methyl transferase. That is phenylethanolamine N-methyl transferase. You can remember just as N-methyl transferase. This is the synthesis of neurotransmitters of adrenergic nervous system. And before we see, before we saw this synthesis, and now we'll see the inactivation of norepinephrine and epinephrine. You just remember this thing as reuptake mechanism and metabolism. We need not to go in detail into what is reuptake mechanism and what is the metabolism in detail. Just for namesake, you just remember how these are inactivated. How means reuptake mechanism and metabolism with the help of two enzymes, monoamine oxidase and catechol O-methyl transferase. So these are metabolized by monoamine oxidase and catechol O-methyl transferase. These are the two enzymes which are responsible for the metabolism of epinephrine and norepinephrine. Right. So next, we'll talk about the adrenergic receptors. These adrenergic receptors are divided into two categories: alpha receptors and beta receptors. Alpha receptors again divided into two: alpha 1, alpha 2. Beta are divided into three: beta 1, beta 2, and beta 3. And now I'll be talking about the locations of these receptors and what are the functions of those receptors. Right. See here, alpha 1, where the alpha 1 is located. So these are the places where alpha 1 is located: iris, radial muscle, vascular smooth muscle, salivary gland, urinary bladder, neck, urinary urethra, and liver cell and intestine. Here, what are the functions of those alpha 1 receptors in these places? Means at everywhere, like on all at all the locations except at intestine, it shows excitatory action. Only at intestine it shows inhibitory action. So alpha 1 at intestine it shows inhibitory action. What do you mean by that inhibitory action? At all places excitatory action means iris radial muscle. If it is excitatory, it produces mydriasis. And vascular smooth muscle excitatory action means constriction. So like that, at every place it shows excitatory action except at intestine it has inhibitory action. That means inhibitory action means regarding that inhibitory action, I will be talking about in detail in GIT section. So just as of now, you just remember that intestine, it has inhibitory action, right? So alpha 2. Where this alpha 2 is located? It is located at brain, platelets, beta pancreatic cells, and vascular smooth muscle. At all these places, alpha 2 has inhibitory action, right? So where these beta 1, beta 2, beta 3 are located? Beta 1 located at heart and extraglomerular cells. It shows excitatory action. Excitatory action means, so at heart, increases force of contraction, increases heart rate, increases contraction, increases conduction velocity. All these things are increased. In extraglomerular cells, increase renin release. Increase renin release. So at beta 2, at bronchi, coronary artery, smooth muscles, uterus, and all these things are like smooth muscles, types of smooth muscles. At all these places, it show relaxation. That means bronchus means bronchodilation, coronary artery means coronary artery dilatation, uterus, it undergo relaxation, and myocardium and skeletal muscle. And beta 3, the main locations, principal locations are bladder and adipose tissue. What are the functions? Bladder, it undergo relaxation. And regarding this relaxation, I'll be talking about this relaxation in urinary section. And adipose tissue, it produces lipolysis. These are the functions, right? Alpha 1, alpha 2, beta 1, beta 2, beta 3. What are the like where these receptors are located, and what are the functions of these receptors at those places? Till now we covered these receptors, right? So now, after finishing these receptors, we will know the responses of effector organs to sympathetic stimulation. Okay, if sympathetic stimulation happens, what happens to these receptors, how they will react for that stimulation, all those things we will talk now. So on respiratory system, what are the effects? It leads to bronchodilation with the help of beta 2 receptors and decongestion with the help of alpha 1 and beta 2 receptors. And on CVS, I told with the help of beta 1 receptors, it increases rate of contraction, force of contraction, and conduction velocity. All those things are increased with the help of beta 1 receptors. Next, on blood vessels. Here in first section, skin, mucosal blood vessels, splanchnic blood vessels, and renal blood vessels, they all undergo vasoconstriction. And these skeletal muscle blood vessels, liver, and coronaries, they undergo vasodilatation. Here, these parts undergo vasoconstriction and these parts undergo vasodilatation. Because here alpha 1 receptors are predominant, here beta 2 receptors are predominant. We just remember this, alpha 1 receptors and beta 2 receptors. If we stimulate alpha 1 receptors, it leads to vasoconstriction. If we stimulate beta 2 receptors, it leads to vasodilatation. So, how to remember this in an easy way? You remember this A, B, C, D. Alpha vasoconstriction, beta vasodilatation, right? So in this way you can remember this vasoconstriction, vasodilatation of blood vessels. So uh, this is important, please concentrate here. Regarding blood pressure, so how blood pressure is regulated? Adrenaline, these are the affinities for the adrenaline on different receptors. Like it has more affinity towards beta 1, sorry, beta 2, and next affinities for beta 1, alpha 1, and alpha 2. And for noradrenaline, the it has more effect on alpha 1, followed by alpha 2. It has equal affinity, and later beta 1 and beta 2. So adrenaline has more effect on beta 2 receptors, and noradrenaline has more effect on alpha 1 receptors. So, what are the effects on systolic and diastolic blood pressure? Adrenaline, it increases the systolic blood pressure but decreases the diastolic blood pressure, which is not a good thing. So that's why we don't use adrenaline for majority of the shocks. In anaphylactic shock, we use adrenaline, but in majority of the shocks, we use noradrenaline because it increases both systolic and diastolic blood pressure. So we prefer this noradrenaline in majority of shock conditions, except in anaphylactic shock where we use adrenaline. And we don't use adrenaline in majority of the situations because it makes the myocardium more susceptible to arrhythmias. So patient may land up in arrhythmias and he may die. So that's why we don't use adrenaline in majority of the situations. Here it increases the BP with a tachycardia. Noradrenaline increases the BP with bradycardia. These are the small differences between adrenaline and noradrenaline, right? So first I told receptor affinity and how it is going to increase and systolic and diastolic blood pressure and increase the BP with tachycardia. Here increase the BP with bradycardia, right? Here I would like to say one small concept, that is vasomotor reversal of Dale. So let's see what is that vasomotor reversal of Dale. Suppose this is our normal BP, 120 millimeters of Hg. Suppose I gave adrenaline. So what happens after giving adrenaline? Initially that 120 it comes to 160 because of alpha action. I told before, right? Alpha 1 and beta 2. Alpha 1 leads to vasoconstriction, beta 2 leads to vasodilatation. So with alpha 1 it leads to vasoconstriction, definitely it will increase the BP. So after some point beta 2 receptors gets activated and leads to vasodilatation. What happens after vasodilatation? It decreases the BP. That is what the thing happening here. So it is a normal blood pressure. So if we give adrenaline to a patient, it increases the blood pressure from 120 to 160. After some point, beta 2 receptors get activated. So beta 2 receptors leads to vasodilatation and decreased blood pressure. So blood pressure decreases and it comes to some 100. And later, again after some time, after metabolism of adrenaline, again it comes back to normal thing, normal 120. This is the normal one. If you give adrenaline, this is what happens. But what is this vasomotor reversal of Dale then? Suppose with adrenaline, if you give alpha blocker, if you give alpha blocker, what happens? If you give alpha blocker, this part will not be there. So this is normally the alpha action. That part will not be there. So only what happens? Only decrease will be there. So this is a normal 120. If you give adrenaline along with alpha blocker, that raising part will not be there. Only downfall will be there. Again after some time, again it comes back to 120. This is called vasomotor reversal of Dale. This vasomotor reversal of Dale is shown by this reverse of V is A. Simple. This reverse of V is, this is what we get. Reverse V. That is adrenaline. So vasomotor reverse of Dale is shown by adrenaline, but it is not shown by noradrenaline. You just remember. So which shows vasomotor reversal of Dale means vasomotor reverse adrenaline. So when we'll get that vasomotor reversal of Dale means if you give adrenaline along with alpha blocker. So if we give adrenaline along with alpha blocker, we will get this vasomotor reversal of Dale. This is one small concept, that is vasomotor reversal of Dale. So next in GIT, what are the functions of the sympathetic nervous system in GIT? So decreases the tone and motility and decrease the influx of water, sodium into the lumen and increases the sphincter contraction. So this is what the thing here, and what are the receptors responsible for those functions. Actually, the sympathetic stimulation means it is useful when you are in fight or flight response. Suppose if you are fighting with someone, you are fighting with your friend, you need this sympathetic stimulation. Suppose you saw one tiger or lion, can you fight with that one? Definitely you can't. So at that time, what you will do, you will flight from there. So you will escape from that situation in order to save yourself. So in that situation, you need to run from that place. So at that time also we need sympathetic stimulation. So during that sympathetic stimulation, suppose just imagine if you are feeling to go to washroom during that situation, it doesn't seems good, right? It seems a bit awkward. So when sympathetic stimulation happens, at that time you should not feel like going to washroom or you should not feel like going to toilet, right? So what at that time our body will make changes in such a way. So decrease the tone and motility means definitely you will not feeling like going to washroom, because if you want to propel the contents of intestine, there should be increased tone and increased motility of the intestine in order for propulsive movement of contents in the intestine, and decreased influx of water and sodium with the help of alpha 2 receptors, and increase sphincter contraction. So if you want to defecate, definitely your sphincters should in relaxed position. But here, if sphincters are in contracted position, definitely you will not feel like going to washroom. You will not feel like feeling to defecate. So these are the pharmacological actions of sympathetic nervous system at GIT. So next, we'll be talking about genitourinary system, and now we'll talk about urinary system first. I told you during fight or flight response, you should not feel like going to washroom. So it promotes the urinary retention. That means all the urine will be stored in bladder. So increase the tone and motility of ureter with the help of alpha 1 receptor, on detrusor muscle relaxation with the help of beta 3 receptor. I told beta 3 receptors are located in two parts. Number one, detrusor muscle, and number two, adipose tissue, right? And trigone constriction and sphincter constriction, right? Suppose if his sphincters are constricted, definitely you can't pass urine with the help of alpha 1 receptors. So this is what the thing with the urinary system: increase the tone and motility of the ureter, and detrusor muscle relaxation, trigone constriction and sphincter constriction. See here, this detrusor muscle, this is the detrusor muscle. If it is, I think you might have learned all these things in your physiology, but just like a glimpse, I'll be giving small uh, thing here. This detrusor muscle, if detrusor muscle is contracted, you will pass urine. If detrusor muscle is relaxed, you can't pass urine. At the same time, in order to pass the urine, detrusor muscle should be contracted, along with sphincters should be in relaxed position, right? So these are the sphincters: internal urethral orifice, external urethral orifice, their sphincters are present. This is the trigone. So here trigone should be relaxed, and the sphincters should be relaxed. Orifice, sorry, trigone should be relaxed and sphincters should be relaxed, and detrusor muscle should be contracted in order to pass the urine. But here all things will be opposite. Detrusor muscle will be relaxed position, sphincters and trigone will be in contracted position. So urinary retention will happen. So coming to reproductive system in rats, and regarding this reproductive system, the actions of adrenaline, it varies from genus to genus, species to species, and in rats it will show one action, and humans it will show another action. Even in humans, in non-pregnant uterus it show one action, and in pregnant on pregnant uterus it shows another action. Non-pregnant uterus it shows contraction, and on pregnant uterus it shows relaxation, and in males it promotes ejaculation with the help of alpha 1 receptors. And on skin, the actions of sympathetic nervous system are: it increases the sweat and it causes a piloerection. And on eye, it produces mydriasis, decreased intraocular pressure, and eyelid constriction, all with the help of alpha 1 receptors. And on skeletal muscle, it has anti-fatigue effect. So definitely during fight or flight, you should run or you should fight. So at that time, your skeletal muscles should not have that thing. You should not feel fatigue. So definitely you should not feel fatigue when you are doing some work, when you are fighting or when you are running. So this anti-fatigue effect is contributed by beta 2 receptors. And metabolic effect, it increases the free fatty acids and increases the lactic acid and increases the glucose. And here in comment section, just give me the reason, what is the purpose of increasing the glucose level with the help of sympathetic stimulation. So what that increased glucose will do, and what is the need of that increased glucose for sympathetic stimulation? So please comment down in the comment section, right? So next, here this is a small like concise table for what all I told before. Uh, Effect of sympathetic nervous system on respiratory, heart, blood vessels, GIT, kidney, reproductive system, skin, eye, skeletal muscle, and metabolic effects. And these are the effects. And you should feel that right part of the table, and if you can make this one in a single paper, that will be very easy for you people to go through just before the examination. For just revision purpose, it will be like a rapid glimpse for you people. So try to concise all the information in one single sheet of paper with this tabular column. That will be very useful for you in your this examination purpose, right? And coming to drugs now, sympathomimetics. Sympathomimetics means the drugs which act like sympathetic neurotransmitter like adrenaline or noradrenaline. These are divided into three categories: directly acting, indirectly acting, and mixed acting. Directly acting means they directly act on receptors. Indirectly acting means they do not directly act on receptors. They make adrenergic neurons to release more epinephrine or more norepinephrine, so that the released epinephrine or norepinephrine will act on the receptors. And mixed means combination of directly acting and indirectly acting. So, see, directly acting sympathomimetics are divided into catecholamines and non-catecholamines. Catecholamines again divided into endogenous that are present in our body, and synthetic which are administered from outside. Administered from outside. Endogenous are norepinephrine, epinephrine, and dopamine. Synthetic phenol-dopam, isoprenaline, dobutamine, dopexamine, and dipepwefrin. Non-catecholamines includes alpha-1 agonist, alpha-2 agonist, beta-1, beta-2, beta-3 agonist. And these are the classifications. Alpha-1 agonist include methoxamine, midodrine, nafazoline, oxymetazoline, xylometazoline, and phenylephrine. And alpha-2 agonists include epreclonidine, brimonidine, clonidine, alpha-methyl dopa. This one you can remember very easily with the help of small mnemonic MNOP. Methoxamine, nafazoline, oxymetazoline, xylometazoline, and phenylephrine. So MNOP, right? Methoxamine, midodrine, nafazoline, oxymetazoline, and xylometazoline, phenylephrine. This alpha 2 agonist you can remember with the help of mnemonic ABCD. Epreclonidine, brimonidine, clonidine, and dopa. Which dopa? Alpha methyl dopa. Epreclonidine, brimonidine, clonidine, and dopa. This one, methoxamine, midodrine, nafazoline, oxymetazoline, xylometazoline, and phenylephrine. Right? In this way, you can remember these drugs. And coming to non-catecholamines, alpha-1 agonist, alpha-2, and alpha-3. Alpha-1 agonist are prenalterol is nothing much. It is just a pharmacological tool. No use, no therapeutic uses. And beta-3, mirabegron, and BRL-37344. This is also a research tool. We don't use that one. And coming to alpha 2 agonist, it includes short acting, that SABA means short acting beta 2 agonist, and LABA means long acting beta 2 agonist. And in short acting, we have terbutaline and salbutamol, and long acting, we have formoterol, e-formoterol, and salmeterol. And we'll be talking about all these things now. Coming to epinephrine. Epinephrine, I told pharmacological actions, all those things which I told before that I asked you people to make the tabular column, right? You can write all the pharmacological actions. And coming to pharmacokinetics, orally it is not at all effective. Why? Why it is orally not effective means it undergoes metabolism with the help of monoamine oxidase and catechol-O-methyl transferase. So that's why it is not effective. So that is a preferred route of administration. So how we'll give this epinephrine means via IV. So this is what the thing with epinephrine. And then, so what are the uses of epinephrine? This is the most important, very, very, very important question for you people. Just remember this one. The therapeutic uses of epinephrine, it can remember as A, B, C, D, E. This is a very, 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 very important question. Just remember, A means anaphylactic shock, B means bronchial asthma, C means cardiac arrest, D means duration of local anesthesia is increased, that is prolongation of duration of action of local anesthesia. E means epistaxis control. So this is how you remember the therapeutic uses of adrenaline: A, B, C, D, E. Anaphylactic shock, bronchial asthma, cardiac arrest, duration, increase the duration of action of local anesthesia, and epistaxis control. So here now we'll be dealing about each and every subheading. Anaphylactic shock. Anaphylactic shock. What is that? And regarding this anaphylactic shock, you just as of now you just remember importance of adrenaline in anaphylactic shock, because this anaphylactic shock itself is a complete very big topic which will be covered by myself maybe in August or September. So here I'll be talking about the role of adrenaline in anaphylactic shock. So it is a drug of choice for acute hypersensitivity reaction. This adrenaline is a drug of choice. How you will give means injection adrenaline, preferably IM, 0.3 to 0.5 ml in 1 is to 1000, right? See here, 1 milligram 1 is to 1000. Here they wrote on vial itself, they wrote. So we'll be giving 0.3 to 0.5 ml. So when we will give IV, here I told we will give via IM only. We will give IV. Suppose you gave IM, patient is not responding. Again, in second chance also, second time also you will give IM only. But still patient is not responding. That is adequate circulation is not there and adequate absorption is not there. At those situations, we'll give IV. So if IM fails, we'll give IV. But that IV we should give in very slow manner and in diluted form. Right? Slow and diluted form. Suppose if you give fast and undiluted form, it will leads to fatal arrhythmias and patient will die. So this is what the thing with adrenaline. And these are the doses, adrenal doses in anaphylaxis. If it is adult, if it is child. If it is adult, IM will give 0.5 ml in 1 is to 1000 concentration. IM, it is 1 is to 1000 concentration, and IV, it has 1 is to 10,000 concentration. IM, 1 is to 1000, IV, 1 is to 10,000. So what does the dose means? IM 0.5 ml, adults, IV 3 to 5 ml. In children, IM 0.01 ml and IV 0.1 ml. Okay, these are the concentrations of adrenaline in anaphylactic shock. So I told anaphylactic shock finished, and now bronchial asthma. In bronchial asthma, in emergent situations, we'll give 0.3 to 0.5, subcutaneous 1 is to 1000 ratio, and cardiac arrest. As of now, you just remember just cardiac arrest. I told A, B, C, D, right? In those things, you just remember C means cardiac arrest. We'll do in cardiac arrest, what we will do? We'll do CPR on all those things, and later we will give adrenaline, defibrillator, all those things, right? Regarding that CPR, I'll be dealing about that emergency drugs used in CPR and all those things in maybe in August or September. So there I will cover in detail about the cardiac arrest. But as of now, you just remember C means cardiac arrest, and D, I told you to prolong the duration of action of local anesthesia. Here we'll be using the concentration 1 is to 50,000 to 1 is to 1 lakh. That may be the subcutaneous or intradermal, and to control the epistaxis. Maybe in removal of tooth or from bleeding from nose like that, we'll give 1 is to 1000 to 1 is to 20,000. We apply topical. Okay, we apply topical. So these are the uses of therapeutic use of adrenaline. So what are the uses then? Anaphylactic shock, bronchial asthma, cardiac arrest, prolongation of duration of action of local anesthesia, and epistaxis control. And this is a very, very, very important question for you people. So prepare well for this adrenaline. Okay. So what are the adverse drug reactions then? Suppose you gave adrenaline, then what are the adverse drug reactions? Means if you give rapid injection, I told if you give fast and undiluted one, it leads to fatal arrhythmias. Rapid injection leads to fatal arrhythmias, and it increases the cardiac workload and cardiac contractility. So it increases the work for heart muscle, and it precipitates pulmonary edema. These are the adverse drug reactions. So rapid injection leads to fatal arrhythmias and increase the cardiac workload and precipitate the pulmonary edema. What are the contraindications of adrenaline? Hypertension, angina, and hyperthyroidism. And coming to noradrenaline now. So noradrenaline L isomer is preferable than D isomer, and our noradrenaline released from postganglionic fibers of parasympathetic system and from adrenal medulla and from pheochromocytoma. This pheochromocytoma is a tumor of adrenal medulla. Okay, it releases more noradrenaline, and receptor affinity, I already told it has more affinity for alpha 1 receptors. So now what are the points for noradrenaline? Means increases both systolic and diastolic blood pressure. That is the reason why it is used in most of the shocks. And cardiac output, CO means cardiac output, it is unchanged, it remains same. and it produces bradycardia due to hypertension. And next, coronary blood flow is increased. And what about vasomotor phenomenon of Dale? I already told you people that vasomotor phenomenon of Dale is shown by V reverse A, that is shown by only adrenaline, not by noradrenaline. So it is this noradrenaline will not show this vasomotor phenomenon of Dale. Okay. Next, what are the uses of noradrenaline? It is used in majority of the shocks, used in shock in order to increase the BP. And what are the ADRs, adverse drug reactions? Suppose if you give subcutaneous or IM or IV in undiluted form, this noradrenaline, we should use this noradrenaline only in diluted form in the form of infusion. Suppose if you use undiluted, it leads to severe vasoconstriction and it leads to hypertension, that is alarming hypertension. So this blood pressure will rise to some 200 and it may leads to some cerebrovascular changes and patient may die. Suppose extravasation of norepinephrine, if it is coming outside from blood vessel because of maybe because of rupture or all those things, it leads to dermal vascular necrosis. So these are the uses and these are the ADRs. And next, coming to dopamine. Here, the dopamine is synthesized from phenylalanine. It is converted to tyrosine. This tyrosine is converted to dopa with the help of tyrosine hydroxylase. This dopa is converted to dopamine with the help of L-dopa decarboxylase. Decarboxylase means removal of CO2. CO2 will come out and it forms dopamine. Okay, this is the synthesis of dopamine. And regarding dopamine receptors, these are the dopamine receptors. Generally, we have five receptors: D1, D2, D3, D4, and D5. This D1 and D5 belongs to one category, and D2, D3, D4 belongs to one category. This is first category, this is second category. So here D1 means it includes D1 and D5. D2 means it includes D2, D3, and D4. Okay. So there are five types of dopamine receptors. D1, 1, 2, 3, 4, 5. 1, 5 belongs to one category, and this 2, 3, 4 belongs to one category. So these are the locations of dopamine receptors and their functions, right? Um, this is the most important thing for you again. Apart from I told adrenaline uses, that is the most important one, and second one is dopamine. These are the dose dependent actions of dopamine. So what are the dose dependent actions? Here I will give one dose, and here you will have one effect. Suppose if I give 2 to 5 microgram per kg per minute, what are the effects? The effects are renal vasodilatation, mesenteric vasodilatation, and cerebral vasodilatation. Suppose if I give 5 to 10 microgram per kg per minute. Suppose if we give a dose of 5 to 10 microgram per kg per minute, we will get all the above effects, as well as you will get increase in heart rate, contractility, CO means increased cardiac output, increased systolic blood pressure, and increased pulse pressure. But the three things will be unchanged. Peripheral vascular resistance, diastolic blood pressure, and mean arterial pressure are unchanged here. And then if you give 11 to 20 microgram per kg per minute, you'll be having predominant cardiac actions. That means here this increase in heart rate, contractility, cardiac output, all those things will be there here, right? And then if it is greater than 20, you will have vasoconstriction. Suppose I told 2 to 5 renal vasodilatation, mesenteric vasodilatation, cerebral vasodilatation, and if it is 5 to 10, all the above. Above means all those things, and these are all the cardiac things. And 11 to 20 you will have all the cardiac things here, and in greater than 20 you will have vasoconstriction, right? This is the most important one. If they ask about dopamine, definitely you should write this table. Definitely you should write this table, and you should mention these are the dose dependent actions of dopamine. Then definitely you will get full marks. That may be 5 marks or 2 marks or anything, whatever it may be, definitely you will get marks. And then coming to what are the use of dopamine? It is used in heart failure patient with oliguria. It is used in cardiogenic and septic shock. Then what are the ADRs of this dopamine? Tachycardia, arrhythmias, angina, hypertension. And we should stop dopamine infusion in the following situations. Where we should stop means it is stopped in three conditions. That you can remember those three conditions as duet. Duet, right? Decreased urine output, and E means ectopic beats, that is arrhythmias, and T means tachycardia. So we should stop these dopamine infusion if there is decreased urine output, if the patient is having arrhythmias, and if there is more heart rate. So these three conditions, it indicates dopamine toxicity. So in this dopamine toxicity, definitely we should stop dopamine. So in these three situations, we should stop dopamine, right? Duet. So here we finish this endogenous catecholamines and coming to synthetic catecholamines: phenol, dopamine, isoprenaline, dobutamine, dopexamine, and dipivefrin. Phenol dopam. Here, if you can see, the name itself is indicating here dopa. Dopa, right? Dopa means dopamine. So it is a D1 action. Definitely vasodilation of renal mesenteric coronary vessels. It is used in the treatment of severe hypertension. And what are the ADRs? Increase in heart rate, increase in intraocular pressure. Intraocular pressure. In IOP means intraocular pressure. And it leads to headache even. Right? And coming to isoprenaline, this isoprenaline also known as isoproterenol, and this is a receptor affinity. It has more affinity to beta 1 receptors. And what are the uses of isoprenaline? Isoprenaline is used in Stokes-Adams syndrome and to counteract the cardiotoxicity with the overusage of beta blockers. And what are the ADRs of isoprenaline? Tachycardia, palpitations, anginal pain, and headache are the adverse drug reactions of isoprenaline. Coming to dobutamine, what are the pharmacological actions of dobutamine? It has more inotropic action than chronotropic action. Inotropic means more contractility, chronotropic means more heart rate, and dilatation of renal and peripheral blood vessels. And what are the uses and ADRs of dobutamine? This one you can remember very easily. Dobutamine, right? So used in refractory and chronic CHF not responding to digoxin, and used in bacteremic shock, and used in ultrasound of that is nothing but echo. And what are the ADRs? Tachyphylaxis, atrial fibrillations, and EMI. This one you can remember from the name itself. Dobutamine, digoxin, where there is zero effect of digoxin. That means in CHF generally we use digoxin, but even after using digoxin also you are getting zero effect. That means if it is refractory, then we will use dobutamine. B, bacteremic shock, bacteremic shock. U, ultrasound of that is nothing but echocardiography. Here we finished uses. And T, tachyphylaxis, ADR, A, atrial fibrillation, and EMI, right? Dobutamine, you can remember that dobutamine therapeutic uses and as well as these ADRs with from the name itself, right? And dopexamine, therapeutic use are used in heart failure and shock, and ADRs are tachycardia and transient hypotension. And dipivefrin, uh, therapeutic uses are it is used in glaucoma, 0.1% solution. And coming to ADRs, this one you can remember with the help of mnemonic PHC, photosensitivity, hyperemia of conjunctiva, that is conjunctival hyperemia. So dipivefrin. So ADRs, you can remember with the mnemonic as PHC, ADRs, and it is used in glaucoma as 0.1% solution. So here we finished this synthetic catecholamines, and now we will talk about non-catecholamines. Coming to non-catecholamines, these are the things we have: methoxamine, midodrine, nafazoline, oxymetazoline, xylometazoline. I told you this one you can remember with the mnemonic as MNOP. An alpha 2 agonist you can remember it as ABCT. Coming to alpha 1 agonist, here phenylephrine and methoxamine are the prototype of the drugs. Phenylephrine and methoxamine prototype, which is used to increase the peripheral vascular resistance (BP) with reflex bradycardia. Where it is used? It is used in shock in order to increase the BP, as nasal decongestants. Phenylephrine used at 0.25 concentration, and methoxamine used at 0.25 concentration and as a mydriatic. Phenylephrine, it is used like with a percentage of 1 to 2%. And midodrine. Midodrine used in the treatment of postural hypotension due to impaired ANS. And what is the ADR for midodrine? Supine hypertension. That is the ADR for midodrine. So it is avoided during the night time. Coming to other things, nafazoline, oxymetazoline, xylometazoline, these are used as nasal decongestants, right? So ideal nasal, this nasal decongestants itself is an another important question for you people. You just remember drugs, okay? This ideal nasal decongestant should produce prolonged and reliable effect, and it should be free from tachyphylaxis, irritation, damaging the cilia, and systemic ADRs. Simple and safest nasal decongestant is ephedrine hydrochloride 0.5% in NS, and this oxymetazoline 0.5% and xylometazoline 0.1% are also nasal decongestants, which is equal effective as ephedrine hydrochloride but with more cost. And these are the common constraints in oral preparations of nasal decongestant. So, what are the common constraints? Like pseudoephedrine, norepinephrine, and phenylephrine. So here we finished this alpha 1 agonist, and coming to alpha 2 agonist, epreclonidine, brimonidine, clonidine, and alpha methyl dopa. That is, you can remember as ABCD. Epreclonidine, brimonidine, where we use it in the treatment of glaucoma. And coming to clonidine, these are the mechanism of actions of clonidine: activation of alpha 2 receptors peripherally, activation of alpha 2 receptors central, that is vasomotor center, and stimulating the imidazoline receptors in brain and decreasing the sympathetic outflow to the kidney. These are the four mechanism of actions of clonidine. And what are the uses of clonidine? And these are the six uses of clonidine, and you can remember like any four is fine. This last you can remember as MAD, right? MAD, menopausal hot flushes, and as an anesthetic medication, that is pre-anesthetic medication, and to control the diarrhea in diabetes patients, that you can remember as MAT. And the everything total six uses, you can remember it as BMW. That is, BMW is a car, it is a very costly car. BMW MAT, right? It costs around some 50, 60, 70 lakhs, or maybe 1 crore even. And some people will have the mat for that car, like I want to buy that car, ఆ కార్ నేను కొనాలి, ఆ కార్ కొనుక్కొని నేను తిరగాలి, ఇట్లా లైక్ పిచ్ ఉంటుంది అనమాట కొంతమందికి. సో యూ కెన్ రిమెంబర్ దట్ clonidine therapeutic uses with the help of mnemonic BMW MAD. B means to control the BP, that is anti-hypertension medication. M means used in migraine prophylaxis. W means withdrawal of alcohol, withdrawal symptoms management for alcohol, nicotine, and opioids. M, I told menopausal hot flushes. A, anesthetic, pre-anesthetic medication. D, to control the diarrhea in diabetes patient. So this clonidine uses you can remember as BMW MAT. So here we finished this clonidine therapeutic uses, and now we will talk about clonidine adverse drug reactions. This clonidine adverse drug reaction, this one also you can remember with a small mnemonic. This is DNS. Normally it should be like this. If it is like this, it is known as DNS. That means deviated nasal septum. Deviated nasal septum. So this mnemonic you can remember it as deviated nasal septum pix. D, dermatitis. N, nasal stuffiness. S, sedation. P, parotid pain. I, impotence. C, constipation. And if you sudden withdrawal, it leads to rebound hypertension. So clonidine uses, it is remembered as BNW MAD, and clonidine adverse drug reactions, it is remembered as DNS PIX. Coming to alpha methyl dopa, this alpha methyl dopa is a centrally acting antihypertensive agent. What are the advantages of this alpha methyl dopa? Means it is a preferred drug in the pregnancy and decreases the ventricular hypertrophy and decreases the renal vascular resistance. And what are the ADRs of this alpha methyl dopa? I told ADRs of clonidine are remembered with the help of DNS PIX. And this one, alpha methyl dopa, you can remember with a mnemonic as Prasad. P, Increased prolactin, what happens if prolactin levels are increased? It leads to gynecomastia in males and galacturia in females. And positive cum test, that is immunological test, are reversible hepatotoxicity, and anemia. Yes, sedation, it is the most common one, it is the most frequent one. Sedation. Arthralgia, pains. D, dry mouth. So you can remember this alpha methyl dopa adverse drug reactions as pressor. Increased prolactin, positive cum test, reversible hepatotoxicity, anemia, sedation is the most common one, arthralgia, and dry mouth. So here we finish the clonidine and alpha methyl dopa, and this one non-catecholamines mainly used as a vasopressor agents, and this is the most important question for you, maybe like 2 marks or maybe 3 marks, I don't know, maybe like short answer. So just remember the names. Vasopressor agents means you have to remember these four names: norepinephrine and phenylephrine, methoxamine, and mefentrhamine. These are the four agents which are used as a vasopressor agents. Why they are used? These correct the hypotension due to cardiogenic shock or neurogenic shock. They correct the arrhythmias associated with hypotension and treatment of paroxysmal atrial tachycardia. And coming to these beta agonist, beta 1, beta 2, beta 3, and prenalterol and mirabegron, we are not using those things, those two agents now. So here now we'll be talking about terbutaline, all these beta 2 agonists, right? Terbutaline, these terbutaline, you can remember all the points of terbutaline in an easy way from the name itself. So terbutaline, it causes tooth erosion, and so this terbutaline, it causes tooth erosion, and then tooth erosion, or it is a resorcinol derivative, so it is not metabolized with the help of catechol-methyl transferase. So tooth erosion and resorcinol derivative, and B, it is used in bronchospasm. U, it is used in urticaria to arrest the labor. TAL, to arrest labor, premature labor, and in emergency situations. In emergency situations like status asthmaticus. So this is what the points with terbutaline. You can remember the terbutaline. Terbutaline. So causes tooth erosion, resorcinol derivative, used in bronchospasm, unresponsive urticaria, bronchospasm, unresponsive urticaria, to arrest labor, and in emergency situations, right? So these are the points with terbutaline. And salbutamol, it is a beta 2 agonist at bronchial smooth muscles and on uterus. And formoterol and salmeterol. This formoterol onset of action is very quick, so used in emergency situations, and duration of action is long. And where we use this formoterol, it is used in COPD, nocturnal asthma, and exercise-induced bronchospasm. And salmeterol, it is used in nocturnal asthma. And here, this onset of action is slow, so onset of action is slow means we can't use that one in emergency situations, right? So here we finish this directly acting, and now we'll talking about indirectly acting and next mixed acting. Sorry, here we finish this indirectly acting, and now we'll be talking about mixed acting, this amphetamine and ephedrine. So what are the actions of amphetamine on CVS? Increases both systolic, diastolic blood pressure, heart rate, followed by bradycardia. On other smooth muscles, it has constriction of urinary sphincter. On CNS, it is a CNS stimulant, produces psychic effect, and it suppresses the appetite. So what are the therapeutic uses of amphetamine? It is used in ADHD, that is attention deficit hyperactive disorder in children. It is used in narcolepsy, and it is used as anorexiant. And what are the ADRs? That is adverse drug reactions of amphetamine. Hypertension, angina, arrhythmias, psychosis, neurosis, and hyperpyrexia. Ephedrine on CVS increases the rate, force of contraction, and increases the blood pressure. On smooth muscle, relax the bronchial smooth muscle and uterine smooth muscle. On CNS, it is used as CNS stimulant. On eye, it produces mydriasis. What are the uses of ephedrine? Asthma, hypotension during spinal anesthesia, and nasal as it is used as a nasal decongestant. That is pseudoephedrine is used, and it is used in Stokes-Adams syndrome and as a mydriatic it is used. And these are the uses of ephedrine, and it is important one for you uses of amphetamine and use of ephedrine. Okay. And if they ask about what are the therapeutic uses of sympathomimetic drugs, these are all the uses. What are I told you now, and I just compile all those things in 2 slides and I put here. Uh, what are the uses means asthma as a nasal decongestant, in hypotension, shock, orthostatic hypotension, emergency management of heart block, echocardiography, anaphylaxis, and ophthalmic uses like as a mydriatics, ADHD, narcolepsy, weight reduction to arrest the premature labor, cardiac arrest to prolong the duration of action of local anesthesia, topically to control the bleeding. So this is also important thing for you if they ask therapeutic uses of sympathomimetic drugs. Till now, we completed sympathomimetics, and now we talk about adrenoreceptor antagonist. And these antagonists are divided into two types: alpha blockers and beta blockers. Alpha blockers are again divided into non-selective, selective, and these are the drugs. And non-selective drugs: phentolamine, tolajocin, and phenoxybenzamine. And selective drugs: prazosin, doxazocin, tamsulosin, and yohimbine. Phentolamine. Coming to phentolamine, what are the uses of phentolamine here? It has three uses: used in pheochromocytoma, used in hypertensive emergencies, and to reverse the action of local anesthesia. This one you can remember with a small thing here. Phentolamine, name itself, phentolamine, right? What are use of phentolamine means? Used in pheochromocytoma, used in hypertensive emergencies, and to reverse the action of local anesthesia. To reverse the action of local anesthesia, right? Using pheochromocytoma, hypertensive emergencies, and to reverse the action of local anesthesia. So these are the uses, and the ADRs means all secretions are increased and causes postural hypotension. These are the thing with the phentolamine. And this I told about phentolamine. Tolajocin is just less potent than phentolamine. And phenoxybenzamine, it is more potent than phentolamine, and it is used in pheochromocytoma. And coming to these selective ones, prazosin, doxazocin, damselozin, and yohimbine. Prazosin, it is used in hypertension, benign prostatic hyperplasia, and peripheral vascular disease. And doxazocin is used in hypertension, benign prostatic hyperplasia. And tamsulosin, this tamsulosin is used in benign prostatic hyperplasia and removal of ureteric stones in distal urethra. And what are the ADRs of tamsulosin? Amblyopia, blurred vision, and increased risk in cataract surgery, and okay. So, um, this selective beta block. Suppose if they ask about beta blockers, you have to write the classification: non-selective, selective, and mixed. And coming to non-selective, propranolol, timolol, sotalol, and selective metoprolol, esmolol, and nebivolol, etanolol, and butoxamine is a selective beta 2 agonist. And coming to mixed labetalol and carvedilol, these are the drugs. All drugs they end with lol, right? So these are the beta blockers, non-selective, selective, and mixed. And now I'll talk about propranolol. Propranolol, coming to what are the uses of propranolol? These propranolol uses are cardiac uses and as well as non-cardiac uses. Cardiac uses are used in hypertension, heart failure, angina, arrhythmias, and myocardial infarction. And what are the non-cardiac uses? Non-cardiac uses are glaucoma, anxiety, used in migraine, and used in esophageal varices. The non-cardiac uses you can remember with the mnemonic GAME, game, right? With that mnemonic, you can remember the non-cardiac uses of propranolol. Sorry, non-cardiac uses of propranolol, right? Game, glaucoma, anxiety, migraine, and esophageal varices. So next, after propranolol, Coming to selective beta blockers, these selective beta blockers are also known as second generation beta blockers, and these are also known as cardio selective beta blockers. So these are only the majorly they are used for cardiac diseases. What are the advantages of these second generation beta blockers over non-selective or first generation beta blockers? Means they are safe in asthma, safe in diabetes mellitus patients, safe in peripheral vascular diseases. And what are the coming to mixed beta blockers? Coming to labetalol, what are the uses? Used in hypertension elderly patients and hypertensive emergencies. Coming to 8 years, usually liver toxicity accumulation, it causes liver toxicity. This labetalol, it accumulates in choroid, so frequent eye checkup is needed, and BP decreases. So these 8 years you can remember with the help of this labetalol first three letters: L, liver toxicity; A, accumulation in eye; and B, it causes BP decreases, so hypotension. So coming to second mixed one, carvedilol. Carvedilol mechanism of action, it has blocks the calcium channels and blocks the alpha and beta receptors. What are the uses? Used in hypertension, angina, and CHF. And what are the contraindications of beta receptors? Means that one you can remember with a mnemonic. Like this is a most important one. What are the contraindications of beta receptors? A, B, C, D. Used in asthma, used in heart block, with mnemonic ABCD: asthma, heart block, CHF, and diabetes mellitus. This is the most important one. What are the contraindications of beta blockers? ABCD: asthma, heart block, CHF, and diabetes mellitus. And here is a small thing, maybe which may be useful for you in Viva things. Beta blockers with intrinsic sympathomimetic activity and beta blockers with membrane stabilizing activity. What are the drugs? There are so many drugs, but as of now, you just remember two or three. That's enough for you. Pindolol, penbutalol, alpranolol are the beta blockers with intrinsic sympathomimetic activity, and beta blockers with membrane stabilizing activity: propranolol, labetalol, esbutalol, and pindolol. And that's the end of our session. And I gave you one question, right? What is the need of increased glucose in a response to sympathetic stimulation? What is the role of that increased glucose? Why glucose should be increased? And please do comment answers in comment section. Thank you.